The last time I was on this stage, I shared it with Grace Jones and about 200 other people. It was as though somebody had pressed a button and suddenly the whole audience was on its feet, energized on the stage. And I wonder, looking at this slide, whether you're thinking what I'm thinking. Theresa May, whatever next. This is also the stage in which Susan Boyle, singing the first line of I Dreamed a Dream, transformed the audience from one which was laughing at her to one that was standing up from the seats you're currently in, giving her a standing ovation. My big energizing moment was 40 years ago, visiting Julian Tudor Hart and Mary Hart at Glencorrig in South Wales for my medical student GP attachment. It kept me going for a whole career. There was a similar moment in the Erskine Bridge Hotel 5 miles down the Clyde from here in 2009 at the first Deep End conference, when general practitioners serving Scotland's 100 most deprived communities were convened and consulted for the very first time. We weren't sure what would happen, but needn't have worried. United by common experience and a wish to be heard, there was an immediate buzz and energy in the room. 9 years later, this group has identity, voice, a manifesto, shared activities, camaraderie, and impact. Our title today is Learning from General Practitioners at the Deep End. Not lessons. That would be too prescriptive. One of the first things we did in 2009 was to ditch the idea of a toolkit for GPs to address inequalities in health, something that assumed that experts knew what needed to be done and GPs only needed to be told what to do. I'll describe what's been learned in 9 years of the Deep End project, and Lisa will describe her experience as a Deep End GP Pioneer Fellow. Whether and how that might apply to your practice, well, that's up to you. The Deep End logo shows the deep end of a swimming pool, the steep slope of need, the flat distribution of resource, a sunrise, not a sunset. Top left, a thistle. On the left, a spirtle, our traditional stirring instrument. The whole thing is a flag to rally under. And there's now similar logos and projects in Ireland, Yorkshire Humber, Greater Manchester, and stirrings in Canberra, Pittsburgh, and Denmark. Each project is different, but similar in their passion and commitment to address the inverse care law. The 100 Deep End practices have patient lists in which from 45 to 90% of patients live in the 15% most deprived data zones in Scotland. They deal with blanket deprivation. Most practices have some such patients. They deal with pocket deprivation. So solutions in areas of blanket deprivation also need to be applied pro rata in areas of pocket and hidden deprivation. Research shows that consultations in deprived areas are typically shorter, despite a higher and earlier prevalence of complex multimorbidity. Patient expectations and enablement are lower, especially in patients with mental health as a comorbidity, the commonest comorbidity in a deprived area. GPs report more stress, especially after long consultations. Patients with multimorbidity in affluent areas get 25% more time in consultations, while similar patients in deprived areas get no extra time. There could be no starker illustration of the inverse care law. If a health system is unbalanced in this way, the care of complex patients is less well coordinated. Complications occur earlier. Patients present in crisis in A&E or a hospital bed. Premature multimorbidity becomes premature mortality. That's always been the case in the deep end. And now, due to the manpower crisis, it may start happening in other areas. So there are two issues to address: inequalities in health and the survival of the generalist clinical function. And these issues are linked. Addressing health inequalities in general practice is not about the latest idea and project from colleagues in public health and health improvement. It's about increasing the volume, quality, and range of care for all patients, whatever problems they present, matching resource to need. The silver bullet of general practice, I'm waiting for the slide to come through. The silver bullet in general practice is unconditional personalized continuity of care, especially for the sixth of patients who account for half of the work. The inverse care law is two things. Helen, 2 days ago, described the effect of market forces, but it also operates within the NHS, not as the difference between good care in affluent areas and bad care in poor areas, but the difference between what GPs can do and could do if they were better resourced and better organized. It's been said that old age is a privilege denied to many. In addressing the needs of patients who've acquired longevity, what will be left to address the big differences in life expectancy between social groups? In pandering to the worried well, what about the unworried unwell, with bigger, more complex and earlier multimorbidity, but less knowledge, confidence and agency to cope? For 70 years, the NHS and the medical establishment has been content to let sleeping dogs lie. The Deep End Project has been trying to wake them up. Politicians are well-intended, but poorly informed, with short attention spans, and they're easily swayed by the medical establishment. Promises are made but not kept, such as statements in Parliament by Scotland's First Minister Nicola Sturgeon and previous Cabinet Secretary for Health Shona Robertson, that the additional needs of patients and practices in deprived areas would be addressed via the new Scottish GP contract. It didn't happen. In a talk to this conference 2 days ago, the current Cabinet Secretary made no reference to the inverse care law, nor its contribution to health inequalities in Scotland being the widest in Western Europe. We've learnt the hard way that advocacy based on rhetoric gains attention but no traction. When the music stops, power and resource tend to be sitting in the same places. William Blake, author of Jerusalem, said, "He who would do good to another must do so in minute particulars. The general good, talking of the general good, is the plea of the scoundrel, the hypocrite, and the flatterer." So in the Deep End, we focused on minute particulars so that our advocacy will be based on examples as well as argument. Put half a dozen Deep End GPs round a table for a couple of hours, and you get a rich discussion on almost any topic, drawing on their experience and views. The three governed GPs in this picture have over 60 years of experience between them, all in one place. That's intelligence that is seldom tapped. The challenge was to capture what was said succinctly, coherently, in language free of jargon that was meaningful to participants and to others who weren't there. And there's now over 25 such reports on the Deep End website. That led to the Deep End Manifesto, 6 points: extra time for consultations to address the inverse care law, better use of serial encounters to build knowledge, confidence, and agency, strengthening the natural hub function of general practice at the heart of local health systems, better connections across the front line, sharing experience, views, and plans, better support from the centre, improved leadership at all levels, including GP leadership on the ground. As Tudor Hart said, it all depends on local leadership. Several government-funded projects have given practical expression to these ideas. And when the opportunities came, we were ready. GovernShip stands for Social and Health Integration Partnership, but also remembers Govern's shipbuilding past. It's our flagship project. Each of the 4 practices has a permanent half-time GP locum, giving each GP partner 1 protected session per week to use as they think. Releasing the time of experienced GPs has been a crucial step, energizing the GPs and raising morale. Most have taken on a leadership function on behalf of the group. All have used the time for extended consultations with selected patients, reviewing their problems, digging deeper into their causes, making a new plan, reinvigorating their care, using this needs-based approach to drive integration through the local system from the bottom up. Monthly multidisciplinary team meetings are used to review complicated and urgent cases of vulnerable children and adults. The range of disciplines has increased. Even though their information systems may not be connected, colleagues can access them and share the information at these meetings. The health centre now has 2 attached social workers, an old idea that needed reinvention. Didn't work well at first. Old attitudes and stereotypes got in the way. All change involving relationships takes time. The initial attached social workers were hidebound by strict protocols and high thresholds, so they were replaced by social care workers with less seniority, but more flexibility and ability to address problems before they became a crisis, which was what the GPs wanted. About 8% of the health centre's 14,000 patients received a SHIP intervention. Over time, this made a difference to GP workload. This slide from an independent analysis shows how GP contacts overall have started to dip in GovernShip practices. That's on the left. Whilst in comparator practices serving similar populations in Glasgow, GP contacts are continuing to rise. The GP locums liked being in this arrangement. 3 of them have become GP partners in the health centre. The GovernShip practices became RCGP Scotland's Practice Team of the Year in 2017. 2 of the Govern practices were part of the Link Worker programme, in which 7 deep end practices had an embedded community links practitioner. There's been an explosive increase in such posts called link workers, navigators, connectors, community organisers. They're not all doing the same thing. The deep end link workers were much more than social prescribers. They could hold one-to-one conversations with patients, often serially, not just signposting to community resources, helping some patients to take the first step, but also helping patients who are floundering in the complicated maze of fragmented services that is our health and social care system. And in this way, the link workers bolstered the generalist function of general practice. If it's the patient's problem, it's our problem. The system remains fragmented. That's what all these new posts are a symptom of. But patients are helped through it. An independent evaluation found improvements in mental health in patients referred to link workers, though few of them met diagnostic or referral criteria for specialist mental health help, highlighting, we think, an important gap in services for patients with mental health problems not on their own, but as a comorbidity. Many specialist services are keen to work with general practice, but usually on their own terms, with predictable and often unsatisfactory results. The success of the Link Worker programme, now being rolled out in Scotland, was partly due to their being embedded in practices. The same embedded approach transformed the effectiveness of financial advisors in general practice, first in 2 practices in Parkhead near Celtic Park, and then in the local cluster. In the first year, the project generated more referrals for financial advice from these 2 practices than from the other 42 practices in the East End of Glasgow combined. 80% were new referrals. The average increase in annual income for each patient taking up the referral was £7,000 to which they were entitled. A key condition was that the project should generate no extra work for the practices, and a key component was the financial advisor preparing reports, letters and appeals that the GPs could then check and sign. GPs report that this has given them more time to address clinical problems. The Deep End GP Pioneer Project looks to the future, building on previous projects and schemes in South Wales and North Dublin. 5 Deep End practices have an attached GP fellow, employed for 8 sessions a week. 3 add clinical capacity, addressing the inverse care law. 3 provide backfill to give the host GPs protected sessions, including 1 for a GP lead. GP fellows and host GPs are all involved in service development, sharing their experiences every 6 weeks in a joint meeting. Meanwhile, the GP fellows meet for 2 sessions a week for an academic program addressing their academic and learning needs. All of this learning is summarized and shared on a website. We've been careful not to burden the fellows with the title of pioneers. It's the scheme that's pioneering, a collaboration between host GPs, GP fellows, and academic colleagues working together to imagine and develop their future practice. But don't just rely on me to tell you about the Pioneer scheme. Lisa Robbins will tell you of her experience as a GP fellow. She's from Auchtermuchty in Fife. She has university degrees from Leeds and Dundee. To offer her a Pioneer fellowship, we had to track her down in the Peruvian jungle on a medical team traveling up a tributary of the Amazon in a boat. She's just married a Hungarian. But despite all these travels, her greatest journey, I think, has been 2 years of general practice in Postle Park. Lisa.
Hi, so I'm just one of 5 fellows, as Graham mentioned. I finished my training about 3 years ago, and I worked as a locum for about a year before starting in the project in November 2016. At that time, I had an interest in population health. I had a little knowledge of the Deep End and only very little knowledge of and experience of working as a GP. So today I'll talk to you very briefly just about the impact of the scheme and what I hope the future holds for it and for us as fellows. So Professor Watts already outlined the background and aims of the Pioneer scheme. When I applied to it, I was primarily drawn to the extensive teaching programme, some of which is shown up here, but also to the prospect of working in just one practice in an area of deprivation. In the 2 years since starting the scheme, however, the 4 other fellows and myself have gained much more than simply the knowledge from the extensive teaching programme and the experience of working in these areas of significant deprivation in the north of Glasgow. So the key ingredients, we have had learning and support from experienced GPs within the practice. We've been able to learn more about the communities in which we work and the resources and services within them. We've had this regular deprivation-specific teaching from a wide variety of sources, including third sector organisations. We've had the time and flexibility to work on service development projects, such as migrant health, mental health, screening, prescribing, and vulnerable families. And we've been able to meet with the other lead GPs and fellows on the project on a regular basis, which has allowed sharing of knowledge, it's prevented duplication of work and reinventing the wheel, and it's another platform for peer support. Alongside this, we've also been able to develop our teaching skills by teaching medical students and pre-medical students in different settings. We visited school pupils via a widening access programme to support their applications to medical school. The students that we've met have been really enthusiastic, and there appears to be a demand for more exposure to and learning from the Deep End. There are also softer impacts, which are no less important. The more supportive approach to working has allowed us all, the younger and more experienced GPs alike, to be genuinely enthusiastic about working as a GP. For the experienced GPs involved with the project, they've moved from the brink of burnout and early retirement to feeling renewed energy and enthusiasm for the job. This has been passed on to the students, trainees, and other colleagues we interact with on a daily basis in different settings. We've been able to network with other GPs, health professionals, and third sector organisations and start to build relationships with some of them. We've met with civil servants, and one of us even got to present at an RCGP conference. We've been privileged to see a bit more of the bigger picture, which I don't think is usual for GPs at our stage. So what's been the impact? We've been given time to think, we've been listened to, we've developed leadership skills, and we've established valued roles within our practices. We've been given the opportunity to see the potential of working in general practice and what we can do with just a little bit of extra time. It's obviously more difficult to assess the direct impact on our patients, but this was never the aim of the scheme. In my practice, however, all GPs now have 15-minute appointments, and fairly on, several patients commented on how much better one of the partners looked. Surely a GP who's less stressed and demotivated is better placed to provide good quality care. This has all happened within 2 years, an early and crucial point in what one would hope will be our 30-year careers. This is how I would like to continue working and how I think we should all be working, with a good balance of clinical work and the ability to make this work more efficient and improve services and therefore the care of our patients. So what does the future hold? Of the 5 fellows, all of whom will finish up in the project this month or next, there are 3 of us who are staying on in the same practices, 2 as salaried GPs and 1 as a partner replacing a recently retired partner. 1 will start a salaried post in another deep end practice in Glasgow, and 1 is going into academia. I'm looking forward to staying on in a great practice I know, with patients that I know, and with more knowledge and skills to help a group of people who need it the most. I feel more inspired to work as a GP, and I hope that the next round of fellows will get as much out of the scheme as we have. So recruitment is now underway for the next round of Pioneer Fellows. If you're interested, you can find details on the Deep End GP website, and the deadline for applications is Friday the 19th of October. We all want and need change and improvement within general practice for both ourselves and for our patients. And I think this model of working could be that change. Thanks.
It's not rocket science that the silver bullet for the future are rewarding, satisfying and sustainable careers for GPs, especially seeing and being exposed to GPs, both young GPs and host GPs in their practices. This is a picture of the Deep End Steering Group. It doesn't usually meet over food and wine, but after 50 meetings held every 6 to 8 weeks in the evening after a day's work, we felt there was something to celebrate. Always well attended, these meetings of 15 or so Deep End GPs were the beating heart of the project, stopping it from being just another project trying to change general practice from the outside. And email obviously kept everyone in touch between times. Now, we shouldn't over-egg what the Deep End project has achieved. The inverse care law still exists. Only about 20 of the Deep End practices have benefited from the projects we've described. About 50 have been involved in some way or another, and 25 have not been involved. The journey isn't over, but at least we are on the road. A pre-institutional network of colleagues linked by common cause and a passion for what general practice might achieve. There's no grand plan, only a direction of travel and a commitment to share learning on the way. If and when the inverse care law is taken seriously at a high level, we've shown the way. The Deep End is important because more than ever in the history of medicine, if healthcare is not at its best where it's needed most, health inequalities will widen. as other communities get the benefits of healthcare and poor communities fall behind. So deprived communities need generalists most. But as this audience well knows, the argument for generalism in other settings is very similar, providing solutions to multimorbidity, healthcare fragmentation, overuse of emergency care, resource constraints, and widening inequality. We've concentrated on the 12 C's of general practice: the traditional strengths of consultations, caring, which means setting the bar high, continuity, coordination, and coverage. Don't forget coverage. It wasn't in Starfield's definition. That's what Julian Tudor Hart spent his career working on, population medicine. But there are also new challenges of increasing capacity, building links with community, improvement through creativity, working with colleagues to improve consistency in general practice as a whole, campaigning and competing for power and resource. This traditional mix of strengths, current activities, and future challenges is the subject of a book, The Exceptional Potential of General Practice. The argument for general practice is not based on past glories, or it's not an existential argument based on how good we are. It's based on general practice being the solution to tomorrow's problems of multimorbidity, fragmented care, overuse of emergency care, resource constraints, and inequality. And this book, with 55 authors from 11 countries, attempts to capture where we are. I'm told by the publisher that you can pre-order on Amazon. Come to meet the authors of this book at a conference in Glasgow on the 14th and 15th of February next year. The speakers include Iona Heath, Peter Costin from Drumchapel and RCGP Practice Team of the Year, John Robson from the East London Learning Health Initiative, Alison Pollock, whom you may have heard of, Andy Haynes, Austin O'Carroll, who is at this meeting talking about the North Dublin scheme, Jan de Masner from Ghent in Belgium, John Fry from Wisconsin in the States, plus speakers from the Scottish, Irish, Yorkshire Humber and Greater Manchester Deep End projects. It's a free conference and you're all welcome. Finally, the book and the conference are both dedicated to the memory of Julian Tudor Hart, one of the great pioneers of general practice. And we planned both the book and the conference in a way of which I know he would have approved, not looking backwards, not resting on laurels, but planning and organizing the future together. Thank you. Welcome.